We are going to be talking about Module H, the nervous system. Our nervous system controls and coordinates all of our body functions. It is the reflex centers for our heartbeat and respiration, and it senses and interprets information from outside of the body and then responds to needed changes both inside and outside the body. Our nervous system consists of two main divisions. We've got our central nervous system and our peripheral nervous system. The central nervous system is the brain and spinal cord. Our peripheral nervous system includes all of our nerves that travel throughout our body. The neuron or the nerve cell is the basic unit of our nervous system. These neurons or nerve cells carry messages or impulses through our spinal cord to and from our brain. They're fragile and they take a long time to heal if injured. Some of these are covered and insulated with a protective fiber called the myelin sheath that allows for speed of conduction of impulses, which is really important because if you think about it, just an example, you put your hand on a hot stove, how quickly you're able to pull your hand away. And if you think about how incredible that is, my hand has touched that, my nerves have sensed that heat, sent the message to my brain to be interpreted, and then my brain sends a message back to my hand to say move. And all that happens in a matter of, less than seconds sometimes. So our brain is made up of three parts. We've got our cerebrum, our cerebellum, and the brainstem, which are all, of course, protected by our skull. The brain is divided into right and left hemispheres. The right hemisphere controls movement and function on our left side, and the left hemisphere controls movement and function on our right side. So most of us know this now, but if you have an injury to the right hemisphere of your brain, you're going to have the issues or weakness or paralysis on the left side of your body. Our cerebral cortex is the outer layer. Ideas, thinking, analysis, judgment, emotions, memory, speech, etc. Voluntary movement control are all within that cerebral cortex. The cerebrum, each side of our brain contains 4 lobes. We've got the frontal lobe, which is important for cognitive functions and controlling of voluntary movements or activities. We've got the parietal lobe, which processes information about temperature, taste, touch, and movement. Our occipital lobe at the back, it's primarily responsible for vision. And then our temporal lobes process memories. It also integrates our memories with sensations of taste, sound, sight, and touch. The cerebellum controls balance and it regulates our voluntary muscles. So it produces and coordinates smooth movements. Our brainstem is our regulatory center. It's really important. It controls heart rate, breathing, swallowing, and the opening and closing of our vessels. So if someone's brain dead, this is, you've heard that term before. These voluntary things can't happen these involuntary things aren't happening involuntarily anymore. I was about to skip ahead. We've also got our spinal cord and our other sensory organs. Our spinal cord is located within our spine. It's connected to the brain, and it's what helps to conduct messages between our brain and our body pathways, our body bypathways, I should say. Our sensory organs, this includes our skin, tongue, nose, eyes, and ears, because all of these sensory organs receive impulses from the environment and relay those impulses to the brain, like the example I used with the hot stove. When everything is working well in the nervous system, we're alert and oriented, we have clear short and long-term memory, and our sensory functions are intact, so we can sense heat and cold and pain. Our gait is coordinated and straight. And our reflexes are quick and present. As we age, we do tend to have some hearing loss. Our appetite decreases. We have vision decreases. And in fact, we actually have more trouble seeing blues and greens than we did when we were younger. Our pupils become less responsive to light. And sometimes we have some changes in memory, most likely with a little bit of short-term memory. So some decrease in short-term memory can be attributed to aging, as well as loss of nerve and brain cells, slower response time and reflex time. Sometimes we may see some tremors or jerking motions with age, reduced sense of touch and sensitivity to pain, reduced blood flow to the brain, some forgetfulness, senses decrease in general. And we talked about the hearing and the vision already, but just in general, our senses are going to decrease in function, and therefore our sensitivity to heat and cold are going to decrease as well. So some variations from the normal that we want to be looking out for and reporting right away: changes in gait or movement, complaints of loss of feeling or the inability to move one side of the body, paralysis, seizures, any speech, vision, or hearing changes, confusion, or complaints of numbness, dizziness, or nausea. And now let's talk about some common diseases or conditions associated with the nervous system. You may have heard of a stroke. It's also called a cerebrovascular accident, or a CVA. When we suspect somebody of having a stroke, or they may be having a stroke, this is an emergency situation. It has to be addressed immediately. When we're talking about strokes or CVAs, time is of the essence. Strokes can happen for one of two reasons. One, a blood vessel in the brain has leaked or broken, and so we're having blood coming, leaking out. Or oxygen to an area is disrupted and brain cells die. So two different ways that we can suffer from a stroke. Strokes can be mild to severe. Recall that the cerebrum is divided into right and left halves, or hemispheres. And when we have an injury to the right side, it's going to affect the right hemisphere, I should say, excuse me. It affects the left side of our body and vice versa. So the area of the brain and the size of the area that are affected by the injury, the stroke, will impact the severity of the stroke. And this will impact what signs and symptoms we see, the extent of the disability, and the prognosis, or the likelihood of recovering, or how much we expect that person to be able to recover. After a stroke, a resident may experience hemiplegia, which is paralysis on one side of the body, hemiparesis, which is weakness on one side of the body, expressive or receptive aphasia. When we're talking about expressive aphasia, and make sure you know the difference between these, this is trouble communicating our thoughts with written or with speech or writing. Receptive aphasia is when we have difficulty understanding the spoken or written word. Emotional lability may occur as well after a stroke. This is when we have inappropriate or uncalled for laughing, crying, or expressions of anger. Loss of sensations like temperature or touch. After a stroke, we can suffer loss of bowel or bladder control, so incontinence, and cognitive impairment. So we may see poor judgment, memory loss, inability to solve problems, or confusion. And after a stroke, someone may have dysphagia, which is difficulty swallowing. So again, I know those sound really similar, so make sure you know the difference in dysphagia and aphasia. Our role as nurse aides when someone has a stroke, it's going to vary depending on the severity of the stroke and the region of the brain that was involved. In general, we want to assist the resident or patient to strengthen muscles, keep joints mobile. We're going to be doing range of motion. If they have paralysis or paresis, we might be doing passive range of motion. We also want to make sure they're always in proper body alignment, supporting their extremities, and preventing pressure ulcers or pressure sores. We need to understand that memory loss or confusion can be frightening for the resident and also frustrating at times. Of course, if you know what you want to express, but you just can't express it. So we want to be really patient with these residents and use simple gestures that may be helpful in communicating a message. We want to encourage independence and self-esteem by letting these residents do as much as they can for themselves. We want to be observant for changes in skin condition, especially in areas where pressure sores are more likely. We want to be aware of bath water temperature. Always have them check it. Make sure it's not too hot for them. We want to adapt self-care activities to the residents' new limitations by using assistive or adaptive devices. Making sure they can access their call bell, water, if they use glasses, etc. Making sure to put all those things on their unaffected side so that they can access them. Another thing, to keep in mind, if your resident has lost the ability to communicate easily, this might be a time when using pictures or a book with images might be helpful as well. We're going to talk about Parkinson's disease. Parkinson's is a progressive, incurable disease that causes a part of the brain to degenerate. And this causes muscles to stiffen, our gait to become this shuffling gait. That's a real classic sign that you'll see, a bent posture. And you might even see this pin rolling with the finger and thumb. That's a common sign of Parkinson's as well. These people will have tremors and shaking, and they develop this mask-like facial expression over time as well. Our role is to protect these residents and keep them safe. Assist with ambulation because these residents are at a particularly high fall risk. And of course, we want to assist as needed with daily activities and self-care while maintaining independence for as long as possible. Head and spinal cord injuries fall under the nervous system as well. These can result from accidents like diving accidents, sports injuries, motor vehicle accidents, war injuries. And this can range from a concussion to a coma to paralysis or death. Head injuries may cause permanent brain damage and disability that can be related to the part of the brain that was injured. And when someone has had a traumatic brain injury, this can include personality changes, seizures, memory loss, paresis, or full-blown paralysis. The severity of the spinal cord injury will depend at the level of which the level and force of the injury. So the higher in the spinal cord that the injury is, the greater the loss of function they're going to have. Paraplegia is the complete loss of function that occurs to the lower body. Quadriplegia is the complete loss of function that occurs to both the lower and upper body plus the trunk. Our role when someone has a head or spinal cord injury is to provide emotional support, realizing that sometimes these patients may have or exhibit anger and frustration. It may feel like it's directed towards us sometimes, but to be patient, understanding, and empathetic. We want to make sure that we're doing repositioning of these patients at least every 2 hours or more often. Understanding that immobility may lead to constipation. We're going to want to encourage intake of fluid and fiber to help decrease the chances of that happening. Often when patients have these types of injuries, they may have a urinary catheter. So we're going to want to make sure to provide adequate fluid intake as well, like we've already mentioned. Also proper catheter care, which is a skill that we're going to be learning in class. Sometimes these residents are going to have the compression stockings as well to help with circulation. These patients are often going to need to do coughing and deep breathing exercises to help keep their lungs clear and prevent pneumonia. And we may be instructed to help encourage and support these types of activities. So that concludes the nervous system. And next we're going to be moving on to cardiovascular.